Hello, folks. This is Dr. Al Heuer. I am the co-owner of A&T Lectures with Terry Shenfield. I also teach at Rutgers University in their School of Health Professions and do a bunch of other things as well, including co-edit some textbooks, including Egan's Fundamentals of Respiratory Care. Today's presentation is going to be talking about EKGs or ECGs for the healthcare practitioner, knowing that we have nurses, respiratory therapists, and perhaps some other allied health professionals who are actually going to be sitting in and enjoying this lecture. So some of the learning objectives for this presentation is to review the basic anatomy of the heart. The idea behind that is this is certainly not a presentation on anatomy and physiology, but in order to understand the abnormalities that can occur, it can be helpful to understand some of the key points regarding the basic anatomy of the heart. Describe the cardiac conducting system, which is actually part of that basic anatomy. Discuss the indications for ECGs or EKGs. Summarize the basics of how to analyze an EKG or ECG. Review common dysrhythmias, if you will, or abnormal rhythms, their causes, as well as some of the basic treatments, and to furnish you with additional resources if you guys want to drill down and learn more about this topic. So the conducting pathway, we're talking about the apex of the heart. Sometimes people think the apex means at the top. What that apex basically means is sort of like the point, okay? It's not literally a point. But if you kind of look at the heart, for those of you, probably most or all of you who've taken anatomy and physiology, you know, when you dissected, whether it was a goat heart or a pig heart, whatever, you kind of see the basic structure. And it turns out that the heart will actually taper down, not exactly to a point, but it tapers down in the bottom part, in basically the ventricles of the heart there. But the conducting pathway actually starts at the top. So it does not start at the apex, it finishes there. It starts with the SA or sinoatrial node. And I'm not going to read this slide to you. You can kind of see this pathway where it goes to the AV node. And by the way, the AV node, when the SA node is knocked out for any one of a variety of reasons, you know, disease processes or other, if you will, you know, syndrome that can occur, the AV node will kick in. The good news is the AV node is enough to sustain life. The bad news is it conducts at a slower rate than the SA node. And then going down further, the bundle of His all the way down to the Purkinje fibers. And a little more, again, on you know, a little more granularity on this conducting system. So the SA node, which is what I referred to earlier, will conduct for an adult, will conduct 60 to 100. The AV node or AV junction will conduct at a lower but generally sufficient heart rate of 40 to 60. And then you can go all the way down to the Purkinje fibers, which will conduct at a slow rate of about 30 to 40. ECG, the graphical depiction. This is obviously review for many or all of you, where you actually have your P waves, you have your QRS complex, you have your ST segment and your T waves. In some cases, you'll be able to visualize U waves as well, and we'll talk a little bit about what all those mean. The main thing is that the QRS complex really has to do with the, you know, ventricular contraction. So that's where the action is happening. That's what's actually, you know, accounting for the bulk of the, you know, the cardiac output and the perfusion of the body tissues. Indications for ECGs or EKGs. So individual has some chief complaints of, let's say, chest pain, dyspnea on exertion. The ECG or EKG can be helpful in making a distinction whether or not it's of a cardiac origin or not. Orthopnea, if you think back, orthopnea is individuals who will develop difficulty breathing when they shift positions. So if they go from a laying position to a standing position, they may have some, you know, some issues there. Or if they just plain and simply have difficulty breathing when they're laying down in a supine position, that could be another form of orthopnea. Pedal edema, again, swelling of the ankles, the gravity dependent areas of the body, fainting spells, palpitations. So when, for instance, a fainting spell could not be explained by another cause. Somebody was severely dehydrated, somebody was, there was some severe emotional trauma. If it's not explained by that, then it may, the patient may well be a candidate for an ECG. Past medical history, if it includes heart disease or cardiac surgery or cardiac dysfunction of some major sort. And then if the physical exam reveals certain things, decreased capillary refill, and a jugular venous distension, diaphoresis, or a bundle of things, for instance, chest pain and diaphoresis. So these are not mutually exclusive, but rather, if they have if you will, a bundle or a montage of these findings. Limitations, like anything that we do, whether it's diagnostic or therapeutic or a combination, it has limitations. So the ECG or EKG does not measure the pumping ability of the heart. It measures the electrical activity. Does not show abnormalities in the structure itself. For something like that, you'd need a cardiac ultrasound or other procedures that can be actually done. For instance, going into the cardiac catheterization lab, where you could actually see, some structural issues. Does not have predictive value in large part. You can have artifact that can occur. So you can have a monitor that was placed on demo mode, and the demo was to show supraventricular tachycardia, but it's never been converted back to a monitoring mode. So you could have it, the screen demonstrating supraventricular tachycardia when the patient may in fact have a normal sinus rhythm. Operator technique, so just improper lead placement, or if it's not even improper, a lead was on, a few leads fell off, a cable became dislodged, something along those lines. Lead placement is another form of a limitation, and then any other, generally speaking, any other technical issues. The analysis, so most importantly, is the rhythm of a potentially lethal nature. Does it require immediate attention? Typically, sinus tachycardia does not. It's not to be ignored, but it's not generally regarded as a lethal rhythm, that not necessarily warranting immediate attention. Is the rate normal, slow, or fast? Is the rhythm regular? Is there a P wave? And again, there's a limited amount of coverage we can do in 45 or 50 minutes, but we'll talk about one or two dysrhythmias that are marked by the absence of a P wave. Or if you will, I'm going to call it the misplacement of a P wave in relation to QRS. What is the PR interval? Okay. What is the configuration of the QRS? Are there other characteristics? ST, depression, axis deviation. We really don't spend a lot of time on axis deviation. It's potentially, somewhat important. I author a textbook, a review textbook for the MBRC exams. They spend a question or two talking about axis deviation, but for the sake of time limitations, I really didn't focus on that intensely for this presentation. What is the final interpretation, and what is the recommended action or treatment? So the grid lines, just a quick review. If you recall, I actually do review this stuff briefly when I go for my ACLS recertification. So I recerted last summer, so I'm due to recertify in about a year, almost exactly. And I just take a quick look to see, again, the big boxes are 1/5 of a second or 0.20 seconds, and the small boxes are 1/5 of that or 0.04 seconds. Estimating the rate if it's irregular, so you can use a 6-second technique. The idea is it's irregular. You don't just want to count, a number of boxes necessarily, because that could be misleading because the if you will, rate is irregular. You could select again 6-second interval strip, you count the number of QRS complexes and multiply it times 10. So in this particular case, you're getting an irregular, you're getting a squiggly baseline, okay? So this could be atrial fibrillation. It certainly looks like it. Typically not a lethal, in and of itself, not a lethal dysrhythmia, but it's one that can actually result in blood clots and pulmonary emboli because of the pooling and the, if you will, circular motion of the blood in the atria rather than it being ejected into the ventricles. So it's just something kind of keeping back in your mind. But in this particular case, the rate is approximately 70 beats per minute. So estimating the rate, if it's regular, there's a lot of different methodologies you can use, but you pick a complex that falls on a heavy line, okay? Then you estimate the rate by counting the number of heavy boxes in between. So if there's one heavy box in between QRSs, the rate would be 300. I'm quite concerned. Right? If there are two, it would be 150. Okay. If it's 3 on 100, and so on and so forth. It's a nice little kind of rule of thumb way to, rarely, if you will calculate or estimate a rate at being, 80 versus 88, that's clinically insignificant. What you really want to know is, approximately if it's 80, or if it's 120, or if it's 150. And you also want to know, as you move further up the spectrum, at a heart rate of about 160 or so, 160 or 170 for an adult, what happens is cardiac output will actually fall. So once you go from 150 to 180 to 200, when you start approaching 200, what happens is there's insufficient time for a ventricular filling. So the dirty little secret, or the real problem with that, is not only does your cardiac output drop, but your oxygen uptake increases, because your heart accounts for 22 to 25% of your oxygen consumption. But as the rate goes up, it accounts for more than that. Again, you can also calculate it, using, again, the number of, this is just a little more granularity on actually calculating the rate. The normal rhythm, so in order to kind of see what's abnormal, it may be helpful to examine what is, what is normal before we look at what's abnormal. So normal rate for an adult, we said, is 60 to 100. So, north of that would be, north of 100 would be tachycardia. There's also this subtle term, I didn't formally define it in this presentation, but it's also relative tachycardia. So for instance, if an individual's baseline, like my heart rate is about 55 to 60, resting, at a resting state, okay? So if my heart rate is 90, that's not technically tachycardia, but for me, it's considerably above my baseline. So something to keep in mind. These are guidelines, the 60 to 100, but it's also important to keep in mind. Likewise, if the patient normally runs around 90 and now they're 105, technically they're tachycardic, but they may have just gone up a flight of stairs. They might have just gotten off of an aggravating, Zoom or a phone call, whatever the case may be. PR interval is normally 0.12 to 0.20 seconds. And you can see QRS is less than or equal to 0.12 seconds. So a little bit of the basics on what's normal. So the arrhythmia or dysrhythmia etiology. So what's happening is there's some combination, either individual or combination of at least three things going on. There's a disturbance in the automaticity, okay? What that means in layperson's terms is, we don't think about our heart beating. It beats automatically, okay? And we have these pacemakers that we talked about, AV, SA, et cetera. It happens automatically, pretty much, certainly hope. And again, in some cases, the pacemaker speeds up. In some cases, a new pacemaker, albeit beating at a slower rate, will take over, because the one beating at the higher rate is not functional, or it's functional, but there's some issue with the conducting pathway that we showed you earlier. So conduction problem, slowing or blockage of the conduction, or a combination of these two. Sinus bradycardia. So I'm not going to again read this, but these, why is it bradycardia? It's less than 60. That's the bad news, kind of, sort of. But you do have one P wave for each QRS. The PR interval looks good, and the QRS width looks good as well. Okay. Common causes, myocardial infarction, oh dear, vagal stimulation, such you can get when you're perhaps suctioning somebody hit the carina or doing a carotid massage, increased ICP, where it's kind of this autonomic thing. It's not a good sign, by the way. If the heart rate starts changing because of a head injury, it's generally not a great sign. Or it could be a sign of a normal athletic heart. If you have somebody whose heart rate is, beating at 50. I was a swimmer many decades, not even years, decades ago. We had a guy on the swim team who's normal. He was a runner off season, and then he was on the swim team. This guy was an animal, and his normal resting heart rate was in the upper 30s. So, and there was nothing wrong with him except what was wrong with any one of us. That that ran and swam for hours every day. There's got to be something wrong when you do sports like that for that long every day. Treatment, nothing if the patient is asymptomatic. If they're symptomatic, atropine. Atropine, so ACLS is basically saying you don't use as much of it, okay? They really are saying that if it's symptomatic, you really should pace the patient. It doesn't mean you can't use atropine, but you use a lower dose. It's usually, now it's 0.5 rather than 1.0. But it's something that's in your arsenal, but they want to see these patients paced if they're symptomatic. Sinus tachycardia, so heart rate is north of 100, but not in excess of 150, but your rhythm and your intervals are okay. Some of the causes, hypovolemia, so you think about, you have less blood that's circulating, so the heart has to put out more, or has to pump harder rather. Fever, so things that can increase your metabolism, fever, pain, even anxiety. Catecholamines, even such as medications like albuterol. Treatment is treating the underlying cause. Even things like something I didn't put here, but physical activity. I mean, I put activity, but I'm talking about like things like aerobic activity in particular, is something that could cause it as well. Supraventricular tachycardia. It's really not one dysrhythmia. This slide kind of infers it is, but it's some of the others that follow that I'll be talking about are technically under this umbrella as well. Okay, so why? Very rapid heart rate of 150 to about 250. The P wave may be buried, so it's there. The problem is you can't really see it because the rate is so high. It's buried in the QRS. As is the PRI, or the PR in interval, is difficult to measure, but it may actually be normal. Common causes: ischemic heart disease, excessive catecholamines. Treatment: beta blockers, calcium channel blockers, or adenosine. Atrial fibrillation. So I alluded to this earlier. You see that your baseline is squiggly, no identifiable P waves, chaotic, irregular baseline, and QRS is indistinguishable but irregular. Common causes: enlarged atrium, clinical significance, threat of emboli, decreased cardiac output, if rapid, less ventricular filling, loss of atrial kick. Treatment: a beta blocker, so low pressor, calcium channel blockers such as cardizem, digox, and cardioverting the patient. Some patients are managed just fine with medications for atrial fibrillation. But the big threat, you have this loss of atrial kick, so you have this loss of cardiac output of about 10-15%. That can be significant. It's less of an issue than, again, what can occur because the atria are basically, they're fibrillating. They're not beating rhythmically with the ventricles. You can get this circulating of blood that doesn't go directly into the ventricles. It stays and kind of goes in a circular motion, and blood clots are apt to form, and blood clots that form in the heart can end up obviously in the pulmonary vasculature. Atrial flutter, so where you have a sawtooth baseline. Treatment, by the way, is basically the same as it is for atrial fibrillation. So it's just recognizing the difference and understanding the treatment is similar to what you have for atrial fibrillation. Premature ventricular contractions, which by the way can be innocuous, can be relatively insignificant, or can be very bad. In fact, ventricular tachycardia basically is ongoing, is repeated PVCs. So basically what's going on: premature, a beat that makes the rhythm appear irregular. PVC is not preceded by a P wave, and the PRI therefore is not measurable. Some of the things that can cause this abnormality is hypokalemia, so low blood potassium, MI, so myocardial infarction or ischemia, hypoxemia, hypovolemia. Even things like, if it's an occasional PVC, it could be stress, it could be some caffeinated beverages excessively, things along those lines. Treatment: treat the underlying causes, beta blockers, and anti-dysrhythmic drugs, amiodarone or lidocaine. Ventricular tachycardia is potentially a lethal it's a lethal rhythm. If a patient's in a ventricular tachycardia long enough, the ACLS protocols basically say if the patient's conscious, if they're quote unquote stable, and they're in ventricular tachycardia, it means if they're alert and oriented, if they stay in this long enough, they're probably not going to be. So the idea is if you recognize this and it's real, it's not a test question. It's, really happening with a real patient. We need to get them out of this as soon as possible. So, the rate is generally 100 to 200. P waves are not present, they're not measurable, not present. PRI is not measurable. QRS is wide, bizarre, greater than 0.12 seconds. Causes are similar to PVCs. And the treatment, if the pulse is stable, similar antiarrhythmic drugs as PVCs. If it's pulseless, then immediately begin CPR and rapid defibrillation. Ventricular fibrillation, this is coarse. There can also be a form that's much finer than this. It's a chaotic rhythm. Heart rate cannot be determined. P waves of PRI and QRS are not discernible. Causes MI, acidosis, hypothermia, hypoxemia. Just treatment, ABCDs, or as we say now, CBDAs of ACLS, including immediate defibrillation. So as soon as you can get this patient hooked up to a defibrillator, rapid defibrillation, preferably the first 2 minutes of onset, or during that first 2 minutes from onset, is really critical. After that, the prognosis drops precipitously, particularly after about 5 minutes of being in this rhythm. Asystole, basically electronic disturbance. Some of the causes to your H's and T's, pneumothorax, drug overdose, hypoxemia post-MI. It's not shockable. Immediate CPR unless there's a valid DNR. Some of the TV shows, they showed patients flatlined, so they hook up the paddles and they shock them like you're jump starting your car. It's just that whoever was consulting with them, the healthcare professional on their TV show or movie, wasn't doing their job. Identify and treat the cause. Pacing the patient may, bridge until you can bring them back, but basic troubleshooting. Most important thing also is to make sure that this is not, if the patient's sitting up in bed eating a bologna sandwich, and bologna's bad for you, but eating, let's say, a lean turkey sandwich in the hospital, and this rhythm's coming up, then maybe some leads fell off or something along those lines. I was working in the ICU yesterday. We had a patient who was sitting up in bed, was not eating bologna or turkey, but sitting up in bed. And indeed, the heart rate was reading 0. And there were a bunch of leads that had fallen off. PEA, pulseless electrical activity. So this is where you're looking at your H's and T's. So you actually, this is the opposite of asystole, sort of, where you actually have electrical activity, but you don't have a pulse. You don't have mechanical activity. There you got to look at your H's and your T's, and I stole this right out of American Heart Association, looking at again some of the causes that we've learned about previously, and reversing them. Let's look briefly at heart blocks as well. So what makes a heart block? This particular one. So let me just be real simple on this. First degree heart block is a PR interval which is greater than 0.2 seconds. Period. Okay, it can be relatively innocuous, something that needs to be monitored. Okay, so you can see that there's generally a little bit more than one full box in between the P and the QRS. If you look at the actual strip itself, okay, it's about 1.25 to 1.5 of those boxes. And again, it may be relatively benign. If it's not, in some cases, it's actually caused by the treatment. So the patient may be on digoxin. And if the serum levels are high, they may need to be either stopped or the dose needs to be cut down. Second degree heart block, there's 2 different types. Okay, so you have an irregular rhythm. The ventricular rate tends to be less than the atrial rate. And you can get a prolongation of the PR interval until there's a QRS is dropped. That would actually be known as Winky-Bach, the type 1 or Winky-Bach. And when you take your either your ACCS exam or your ACLS, these are questions that definitely come up, knowing the difference between type 1 and type 2. Causes MI or ischemia, excessive beta blockers, DIG toxicity. Some of the treatment may be atropine if the patient's symptomatic heart rate's less than 60. And monitoring the patient is critically important. And we're moving, type 1 and then the 2 different types 2s. they're more severe than type 1. Type 3 is quite severe. We'll talk about that in a minute. Second degree, type 2. So what's actually happening here is the rate is regular. The ventricular rate is less than the atrial rate. QRS does not occur with each P wave. So it's no prolongation. It's just they're not present in some cases. In some cases they are. So there's something, the pathway works, but it doesn't work consistently. Okay. So there's more P waves than QRS waves. MI or ischemia, excessive beta blockers, dig toxicity. And you can see some of the treatments here are consistent with type 1. Third degree heart block is an interesting one before we actually go into the why, the what, all that other good nonsense there. What is actually happening, it's kind of scary when you think about it, is the atria and the ventricles are not in coordination. Think about what that means. The top part of the heart and the bottom part of the heart are doing their own thing. So you got to say to yourself, well, you know, they're both kind of working. You say, there's got to be something significant, some significant pathology going on for this to happen. Okay. So it's generally regarded as not a good scenario. One of the more, I don't say lethal, but one of the more potentially lethal or malignant forms that can further degrade, into other rhythms that can be more severe. Independent, again, atrial P wave and ventricular activity. The atrial is always faster than the ventricular rate. Heart rate is often less than 40. Think about that. PRI, not measurable. QRS may be greater. So it's kind of this elongated thing that's going on here. So you do have P waves. Okay. That's the good news. Okay. In some cases, you have P waves that you can actually see. In other cases, you can't see them, but there's other forms, other dysrhythmias where you don't have P waves that make them distinguishable, where third degree heart block can further, if you will, deteriorate. Some of the causes, MI or ischemia, dig toxicity. And again, these treatments are consistent with the patient probably needs to be paced. So idioventricular rhythm. I know I'm not trying to make you dizzy. I'm going back here. Let's look they look similar, but I want you to focus. Third degree heart block, there are P waves. Okay. Some of them are buried, but there are P waves. Okay. With idioventricular rhythm, there are not. It's one of the distinguishing features of an idioventricular versus a third degree heart block. So typically the rate is slow in both of them. Okay. But in idioventricular, there's no P waves. And this does come up, and we'll tell you that when you see this, this is typically not, this is a sick heart. So on the scale, and it's not that the patient's not necessarily coding, but it's a sick heart. There's a lot of probably pathology that's going on with this patient with regard to a lot of cardiomyopathy. They may have had multiple MIs. So there's a lot of scarring and dead tissue. So it's not just they've lost pumping ability. So what happens when you have a true MI where the actual tissue dies? Okay, a portion of the myocardium dies. It's not just the muscle, but it's the conducting pathway that's going through that is probably dead as well. Okay, so you can get these more, if you will, potentially malignant rhythms that can occur, or just one massive MI, but typically it'd be somebody who's had more than one. The treatment, pacing, atropine, or further declines if the patient's ejection fraction. I'll talk later in one of my other presentations. I'll talk about things like ejection fraction and cardiac output. But a patient like this probably has diminished cardiac output and ejection fraction as well. So they may eventually become a candidate for things like an LVAD, left ventricular assist device, and then eventually maybe for a heart transplant. Other abnormalities, spend a little bit of time on this, where you look at ST segment elevation and depression. So you could have, when someone actually has ST depression, you're looking at that bottom one there, C, that's myocardial ischemia. So the tissue's not dead, but basically it's they're not receiving enough oxygen. So A would be, I would say, quote unquote, normal. B is a myocardial infarction where you have an ST, a STEMI. ST elevation, myocardial infarction, STEMI. That's what STEMI stands for. The bottom one there is ischemia. So hopefully, probably both of these these individuals, if they're somewhat stable, will end up in the cath lab. Interesting. You take cath labs, for instance, but if you're in a more remote area of the country or in another country, okay, they may actually do something like TPA, the patient. tissue plasminogen activator. So clot busters, because some, we're used to, I'm in New Jersey, Terry's in Pennsylvania, but we have a lot of hospitals in the area. And a lot of these hospitals have cath labs. But if you're in an area of the country or the world that doesn't, then they may actually attempt a different, mode of attacking this problem. There's an ST elevation with a PVC. What's significant about these PVCs is that they're multifocal. The one in the middle looks different than the one all the way on the right-hand side, okay? Which is suggesting that the pathology is multifocal, that the problems with the patient's heart are more widespread than being localized to one area. So acute MI, the patient's actually actively having an MI. Treatment, TPA, again, tissue plasminogen activator, clot busters, vasodilators, cath lab. Revascularization would be actually surgery, but if you want to talk about revascularization, it can be technically accomplished also in the cath lab, where they open up that vessel. They bypass it or they open it up. ST segment depression. So you have ischemia. The treatment you have here, these patients will be, typically on oxygen, not necessarily a non-rebreather, not necessarily, and often not intubated, but they'll have a non-rebreather, or at least a nasal cannula or simple mask on them. So nitroglycerin, the saying used to be Mona will receive these patients in the ED. So morphine, oxygen, nitroglycerin, and probably aspirin. That would be not the long-term therapy, but the immediate therapy. What's significant is if the patient presents to the ED and there's a high index of suspicion that they're having an MI, and they're hooking up the EKG, which is probably they're going to measure cardiac enzymes. The problem with cardiac enzymes is they're not going to show up for at least about 4 hours, give or take, 4 to 6 hours, 3 to 6 hours, depending on what book you look at. So they may well do things like we talk about Mona. They give the patient nitroglycerin. And if the patient has chest pain, which many, though not all of them will have, if they improve with the nitro, it's clinically very significant. It means that they've responded to the therapy. The good news is they responded. The bad news is it probably means they have some sort of an issue with the vascularization of the heart. So take home messages, looking at where we are with time, it's about 3:45. So we're about 40 minutes into this presentation. Some things you really need to focus on. Decide what it is you need and want to know about ECGs, EKGs. Identify the resources, texts, looking at textbooks, manuals, some of the things I'll actually share with you. Review and reinforce. I say that because, I edit textbooks, I teach respiratory care, and I will tell you with great humility that I need to review this stuff. It's like you can only keep a certain amount of things in your head, okay? And then eventually you start stuffing stuff in there, and we all have busy lives. You start stuffing stuff in there, and some of the stuff either gets buried or just pops out. It pops out the right ear or the left ear, whatever the case may be. So it's really important to kind of be constantly reviewing and reinforcing this stuff. The other major rationale for reviewing and reinforcing is the data changes. Okay, now it used to be ABCs, now it's CABs. So we're looking at circulation is really critical, then opening up the airway, then actually breathing for the patient. So things change as we get more data, more information. Obtain and maintain ACLS. I don't receive any. Terry and I have no conflict, so I don't get any royalties from the American Heart Association. It's just a good thing to review, and as well. If you're a respiratory therapist, the ACCS, if you will, sub-designation. My wife's a nurse, so the nursing, association has their equivalent of those as well. It's not just the, CCRN, but some of the other designations that are out there. Know their limitations. It's just, if you have questions, you're looking at a rhythm that you don't understand, or if the patient's monitor is alarming, and you're really not sure, you just, ask for help. Hey, could you come in the room with me? I'm not really, I'm looking at a patient, they're not unconscious, but they don't look quite right. Can we do this together? And, knowing that it may be a code blue, it may be a rapid response, or it may just be a lead fell off and the patient just happens to be having a bad moment otherwise. This is some of the additional resources, including some that I actually use for the chapters that I actually edit on on EKGs and a couple of textbooks that I co-edit. So I'll also do some of the chapters in those textbooks, and I use some of these excellent sources in order to keep keep those chapters updated. So with that, I want to thank you guys very much for attending today's session. Hopefully that you got something out of it, and we look forward to seeing you at future sessions that we'll be presenting. Thanks a lot and have a wonderful day.